My name again is Maggie mentioned. Thank you for the introduction. Is Terry Follin. I'm a licensed professional counselor at Lenape Valley Foundation. I'd like to thank the folks at Bucks County Area Agency on Aging for inviting me, and would also like to thank all of you for allowing me to spend time with you today. This session is all about how loneliness and isolation affects our seniors. It's a topic that and anxiety and depression are things I could probably talk about for hours and hours and hours. So today I'll just talk fast. And Maggie's going to monitor the chat. If you have questions during, we're going to take them. We'll also have hopefully time at the end for questions, comments, concerns, throwing rotten tomatoes at me, whatever. That's the one good thing about virtual is, the screen gets it. Does the ding mean I'm getting a chat? Because I'm not sure what that means. Let me just see.
Anything in the chat, Terry? I think we're okay.
Okay, you'll let me know.
Yeah.
Okay, great. Let me just get back here. All right. So I've broken down the topics into an introduction. We're going to talk about the impacts of isolation and loneliness, specifically depression and anxiety on seniors, ways to help, what works, and things that we're looking at research-wise. Well, people are looking at. So. Okay. There we go. I thought we'd start off by doing some neck exercises. Like March 13th of 2020, I was told Sunday night we got an email that said we're going to start working home from home tomorrow. And yeah, like everybody, or most of us, a lot of us. And I ended up doing some things. I bought a projector monitor to help my eyesight. I bought a bigger phone. I invested a little bit in that. And I noticed sitting here all day talking to folks in therapy can be quite a strain. And so I thought we'd start off today just doing a few neck exercises just to loosen up. I see the warning up here. If you don't schedule time for maintenance, your equipment will schedule it for you. So when I was in my 30s, 100 years ago or so, I was like, self-care, I don't have time for that. I just don't have time. So, and now I run our monthly peer supervision self-care group at Lenape. So please, if you have neck problems, don't do it. This is not mandatory. This is just to get us started and loosened up and so we can get into the discussion. So first is a neck drop and raise. This stretch works both the front and the back of your neck to increase flexibility and movement. These are some exercises I learned from Arthritis Foundation. And I definitely do them once a month at our self-care group. I try to do them more often because they are beneficial, but it's like anything else, you got to stay with it. So the first one is we're going to slowly drop your head forward until your chin touches your chest and count to 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and gently bring it back to center. And then we're going to lean it back slightly and hold it for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. If you hear me groan, that means it's working for me. The next is a head tilt. This opposing motion works the sides of your neck. So we're going to slowly tilt your head toward your right shoulder while keeping your left shoulder down. And we're going to hold it for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and bring it back to center. Remember, gentle, gentle movements. And to the other side, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then is a neck rotation. It's good for the sides of the neck as well. We're going to slowly turn the head to the right and count for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Bring it back to center and to the left. 2, 3, 4, 5, 6, 7, 8, 9, 10. And one more, because everything's connected. We're going to do the shoulder rolls. So we're going to roll the shoulders up and forward for 5 smooth motions. So that's 2, and another one is 3, and another one is 4, and one more is 5. And then anything we do forward, we want to do back. So we're going to go up and back gently. 1, 2, 3, 4, and one more is 5. All right. So that's a form of micro self-care. There's macro and micro self-care. I'm going to talk about self-care a little later. Um, and this is just a little something you can do just while sitting at your desk. Thank you. All right. COVID-19, coronavirus, the vid, some call it, I've heard, remains with us, seemingly ever present. If you work with, live with, are friends with, or are a senior, you all could get up here and give this talk. You've seen and or experienced firsthand how loneliness and isolation affects folks. Seniors have experienced isolation and loneliness, though, long before the pandemic came into play, right? This in seniors can have a deep emotional impact, which can lead to social and behavioral disorders like depression and anxiety. Maybe less well understood or known is the impact on physical health that loneliness can have. I actually saw where one study showed that the effects of loneliness on physical health were like smoking 15 cigarettes a day. The authors noted that actual and perceived social isolation are both associated with increased risk for early mortality. In this meta-analytic review I have up here, the objective was to establish the overall and relative magnitude of social isolation and loneliness and to examine possible moderators. So they conducted a literature search of studies from January 1980 to February of 2014 using Medline, CNOW, PsycInfo, Social Work Abstracts, and Google Scholar. The included studies provided quantitative data on mortality as affected by loneliness, social isolation, or living alone. Results remained consistent across gender, length of follow-up, and world region, but initial health status was found to have an influence on the findings. Overall, the influence of both objective and subjective social isolation on the risk for mortality was found to be comparable with well-established risks for mortality, like smoking. Definitions. I thought we'd take a quick look at definitions. National Institute on Aging, Department of Health and Human Services has this to say. Loneliness and isolation are different but related. Loneliness is the distressing feeling of being alone or separated. Social isolation is the lack of social contacts and having few people to interact with regularly. You can live alone and not feel lonely or socially isolated, and you can feel lonely while being with other people. We know that seniors are at a higher risk for social isolation and loneliness due to changes in health and social connections that can come with growing older, hearing, vision, and memory loss, disability, trouble getting around, and or the loss of family and friends, and oh yes, a pandemic. Loneliness and social isolation have many causes and consequences, including the social bereavement, low social support, lack of transportation, relocation, retirement, financial instability, physical function, again, mobility, self-care, strength, physical health, our perceived health, physical illness, and longevity. I know I still think I can do things I could do back when. Cognitive function, memory, executive functioning, dementia, and mental health, depression, anxiety, hopelessness, well-being, suicide. Um, Pardon me. This model up here is from the National Council on Aging's Mental Health Awareness Day. I attended in May of this year. Dr. Kim Van Orden presented on this, and I'm gonna hone in on how isolation and loneliness can lead to anxiety and depression. The signs and symptoms of depression and or anxiety in seniors can look a bit different. They can also be misdiagnosed, as we said, as other challenges like cognitive decline or impairment. And again, as noted, can greatly impact physical health and well-being. It can be like a cycle where, that's why I have that circle up there. Loneliness and isolation lead to depression and anxiety, which can lead to physical ailments, which in turn makes folks more depressed and anxious. Sadness versus depression. We know sadness and depression differ. Sadness is a normal emotion everyone experiences from time to time, while major depressive disorders are real illnesses that can last for episodes of 2 weeks or more and can cause serious changes in affective, cognitive, and physiologic functions. So there are two cardinals. I'm going to break this down. We're going to talk about major depressive disorder. We're going to talk about anxiety disorder. We're going to talk about depression and anxiety, and then we're going to talk about what's helping. Like I said, like what can we do? All right, two cardinal signs, symptoms of major depressive disorder in adults, including seniors, older adults. Persistently depressed mood, feeling sad, empty, or hopeless most of the day, nearly every day, lasting at least 2 weeks or more. And a marked loss of interest or pleasure in all or almost all activities that were once pleasurable most of the day, nearly every day, lasting at least 2 weeks or more.
Teresa, I'm sorry, it's Maggie. I need to interrupt for a second. Someone's typing, so could they please mute themselves? Their initials are DM. Everyone needs to be muted so that everyone else can hear. We're still having some audio problems. So please, if you haven't muted, please do so. Okay, thanks, Teresa.
Thank you. Appreciate it. Okay, signs and symptoms. This is what's underneath, right? This is for adults and seniors as well. This slide shows what it can look like. Difficulty sleeping, change in appetite, um, fatigue, less interest in sex, trouble getting going. Depression just wants us to stay in bed. Muscle aches and pains, the somatic symptoms, not enjoying things you used to, thoughts of self-harm or suicide, negative self-talk, headaches, feeling down or numb, upset stomach, feeling worthless, hopeless, angry, or irritable, difficulty concentrating or remembering things. You'll see up here some of these things. Symptoms in depression can mimic those of cognitive impairment or decline. So many people believe that depression is a normal part of growing older. But research tells us depressive disorders are not a function of aging, but rather a common group of mental disorders that can be successfully treated. A lot of things can increase the risk for seniors becoming depressed. And research indicates that physical illness and ailments, like we said, as well as disability, can play major roles in the development of depressive symptoms. Also, in addition to those two major symptoms mentioned before, folks must experience at least 4 or more of these: a decrease or increase in appetite, nearly every day, often leading to significant weight loss when not dieting, or weight gain. In seniors, the former is typically seen, as we know, that is loss of appetite and weight loss. Sleep disturbances, oversleeping, undersleeping nearly every day, fatigue or loss of energy, regardless of the amount of sleep each night, nearly every day, difficulty concentrating, remembering, making decisions nearly every day, accelerated or decelerated body movements. These are observed by others. Feelings of worthlessness or excessive or inappropriate guilt, which can be delusional at times, nearly every day, and our thoughts, again, thoughts of suicide or preoccupation with thoughts of one's own death. So, as you can see on the slide, there are other types of depressive disorders without going into detail on them. In therapy school, we are taught at the bottom, I have depressive disorder due to another medical condition. In grad school, we're taught to rule out another medical condition. Again, I'm not a doctor. I don't play one on TV. I'm not. However, a lot of, because it's all connected, which we're going to get into, one medical condition that carries with it a potential symptom of depression is hypothyroidism. So I have had more than several clients whom I've suggested go for a physical and talk with their doctor about their fatigue and sadness and get potential thyroid testing. It's just fascinating. I've had some folks diagnosed with hyper, with Graves' disease, and once they got on medication for their physical diagnosis, the depression lifted that was initially thought to be a mental diagnosis. All right. As previously mentioned, a lot of older adults have chronic medical illnesses that are associated with an increased risk for depression, including diabetes, heart disease, Alzheimer's, Parkinson's, cancer, stroke, chronic pain. In fact, depression is so common in patients with heart disease that the American Heart Association recommends that heart disease patients be routinely screened for depression. And actually, I saw up to 33% of patients who had heart attacks or myocardial infarctions meet the diagnostic criteria for major depressive disorder. Challenges for seniors. Many reasons why seniors may not recognize or report their symptoms to a healthcare provider. The belief that depression is a normal part of the aging process, as mentioned. Lack of awareness that increased somatic symptoms can cause depression, pain, disturbances with sleep or appetite. Again, these can be signs of something medical, physical, or depression, a mental issue. They attribute depressed mood to pre-existing health conditions. I have people myself, embarrassment or shame, the stigma about having emotional difficulties, which, as we know, really just runs across the lifespan. A belief that uncomfortable emotional or physical symptoms should be endured for as long as possible. I wonder if there's going to be I know a lot of folks personally with the stoicism, right? Lack of knowledge about symptoms of mental disorders and a lack of knowledge about where and how to access services and supports. Healthcare practitioners and other service providers may find it challenging to identify depression in seniors, so we got it on both sides, including the belief that older adults naturally experience depression as a consequence of the vicissitudes of aging. So one big thing I've learned is if we're working with seniors, as you know, get trained in how to help folks understand what's going on with them medically, emotionally. The most frequent symptom complaints from older adults may be those not immediately associated with depression, like we said earlier, headaches, pain, stomach upset, changes in appetite. Some cognitive symptoms of depression, like difficulty concentrating or remembering information, again, can be misconstrued as the initial signs of cognitive impairment or decline rather than depression. Again, lack of training to identify symptoms of depression and a lack of adequate systems within the healthcare and social service programs to deliver mental health assessment and intervention. So, risk factors for depression. As we have already seen, depression causes physical symptoms like disturbances with sleep and appetite and fatigue. Also, your sleep pattern changes. You start sleeping a lot more, or you have trouble falling asleep at night, or you wake up really early and you can't get back to sleep. This can also be a function of what I call the normal aging process. Um, your eating habits change, you've lost your appetite, or you eat a lot more. I have up here the mind-body connection. Um, so as mentioned, many seniors have chronic medical illnesses that are associated with an increased incidence of depression, like heart disease, diabetes, etc., neurodegenerative disorders. Additionally, other medical or biological factors can increase the risk of developing depression, including sensory impairment, mobility impairment, past history of a depressive disorder, polypharmacy use. It's good to have a one healthcare provider who is monitoring a person's medications, like not necessarily prescribing or recommending, but somebody who knows everything that person is taking because of the effects of medications on each other. Excessive alcohol use or an alcohol disorder, and changes in the brain's vascular system. Seniors who struggle with physical disabilities big enough to interfere with daily functioning are at an increased risk for depression, especially when those disabilities get in the way of seniors engaging in social activities and relationships. Those who require formal assistance in the home or formal caregiving facilities are more likely to suffer depressive symptoms than those who do not need formal caregiver help. As we know, a way of determining disability is to assess how well folks can perform their ADLs up here, and their IADLs again up here, as we know. This is okay. So we're going into bereavement and grief and mourning in depression. For many seniors, the experience of losing loved ones is common, and grief is a natural and expected reaction. While most seniors have the resilience to weather bereavement over time, lost loved ones can raise the risk for developing depression. It can foreshadow a diagnosis of major depressive disorder. While most seniors can weather grief without developing clinically significant depression, some particularly vulnerable folks may be more likely to experience clinical depression following a significant loss. They include seniors who have already experienced significant or multiple losses, as well as those who have other mental disorders. Grief and depression share some of the same characteristics, like intense sadness and a retreat from usual activities. However, some of the ways that we can distinguish between clinical depression and grief. In clinical depression, as we see, mood and thinking are usually pervasively negative. While in grief, people often experience mixed episodes of painful feelings interspersed with positive memories of the deceased loved one. In other words, they're able to make meaning of the person's life while also mourning their passing, or other positive feelings from time to time can be felt. Depression, not so much. Self-esteem is affected in clinical depression, leading to strong feelings of guilt, worthlessness, and or self-loathing, as we mentioned earlier. And in grief, people who are grieving, they don't usually experience a significant decrease in self-esteem. So, while none of these up here, I listed the role of other types of loss and depression because there's just loss is loss is loss, whether it be a direct loss of a loved one, ambiguous loss, there's loss. And as we age, grief is, I'm finding in my practice, is a common thread that seniors want help with managing. So while none of these psychosocial stressors I've listed up here is a direct cause of clinical depression, each one can elevate the risk of developing depression in seniors who are socially isolated or who do not have the skills to create and maintain new routines or social support networks as they age. Seniors may experience a lot of role changes. Mainstream United States society does not typically value elders, as we know, and as a result, a lot of seniors feel a sense of diminished status because of ageism. While a lot of people look forward to retirement, this stage of life can also be quite stressful, and some challenges include the loss of identity as a wage earner, loss of structure in daily life, loss of a sense of purpose and accomplishment, loss of social connections as contacts with coworkers end, and loss of income in retirement. So, moving on to anxiety, I've broken this down into depression and anxiety, and we're going to look at how, like, they're best friends and how these are what I'm finding in my practice, the biggest impacts for folks, seniors, in who are socially isolated and experiencing loneliness, specifically surrounding the pandemic. So, anxiety. An emotion characterized by apprehension and somatic symptoms of tension in which an individual anticipates impending danger, catastrophe, or misfortune. The body often mobilizes itself to meet the perceived threat. Muscles become tense, breathing is faster, and the heart beats more rapidly. Anxiety may be distinguished from fear both conceptually and physiologically, although the two terms are often used interchangeably. Anxiety is considered a future-oriented, long-acting response broadly focused on a diffuse threat, whereas fear is an appropriate, present-oriented, and short-lived response to a clearly identifiable and specific threat. This slide up here shows common symptoms of anxiety, which include increased heart rate, brain zaps, shaking, trembling, twitching, upset stomach, burning skin, feeling hot, chest or head pressure, blurred vision or eye strain, ringing in the ears, weak or restless legs. You can see how people think that like they're physically sick when they're having maybe a panic attack or feeling their anxiety is escalating. Anxiety is a normal feeling state we all experience from time to time. Again, it's a reaction people have to a perceived danger or threat. Do you need to have all of these for a diagnosis of anxiety? No. Is it possible one could have symptoms of anxiety that aren't up here? Absolutely. So what do older adults worry about? Some anxiety in older age is attributable to legitimate concerns in later life, like health, finances, fear of becoming a burden to others. It becomes a clinical issue, though, when symptoms are experienced with such intensity or frequency that functioning and quality of life are compromised. Anxiety disorders are associated with a high degree of emotional arousal, right? So these include emotional, feeling frightened or scared, nervous, irritable, restless, or on edge. Physical entails headaches again, chest pain, racing heart, fatigue, trouble sleeping, stomach pain, digestive issues, nausea, muscle tension, and dizziness. Behavioral signs can include, pardon me, hypervigilance, always being ready, jumpiness, or a tendency to be easily startled, pacing, and avoiding things that cause anxiety. Risk factors for anxiety disorders include being female, chronic medical problems, sensory or mobility impairment. And as I read these, you can see some of these, if not all of them, are connected to those with depression. Stressful life events, activities of daily living, or physical impairment or decline. Those ACEs, as we know, adverse childhood events, and cognitive impairment. Subtypes, just like depressive disorder, there are subtypes of anxiety disorders, separation anxiety, specific phobias, social anxiety, panic disorder, agoraphobia, and generalized anxiety disorder. That's all about worrying, right? Am I worrying enough? Should I be worrying more? That sort of behavior. This is just to give you an idea of what can be going on with folks. Other subtypes include substance or medication-induced anxiety, disorder due to another medical condition, and other specified anxiety disorders. But they all can affect struggling with these and with those from depression, either and or both. Are how a lot of seniors are this is what's the impact that the social isolation and loneliness from the before and now more so from the pandemic are having on our seniors. So mind-body connection, still, again, as with depression, anxiety and physical health status are closely related. Seniors with chronic health conditions are more likely than the general population to have clinically significant symptoms of anxiety. Some of them include vision loss, diabetes, cardiovascular disease, chronic obstructive pulmonary disease, sensory or mobility impairment, and dementia. And I put this slide up here and I educate folks in my practice that signs and symptoms of anxiety and depression overlap because they're best friends forever if you have them both. The thing with anxiety is it always wants to be in the driver's seat, and depression wants to be in the passenger seat. And that tends to put anybody struggling with anxiety and or depression in the back seat or the trunk. That can leave folks with feeling as if they have no control. The behavior anxiety is always looking for is avoidance. And this goes well with depression because it just wants us to stay in bed. So as we can see down the middle, excessive worry, the somatic physical complaints, difficulty with thinking, concentrating, or decision making, restlessness, agitation, appetite, sleep disturbances, and social withdrawal, they all overlap anxiety and depression, those symptoms. All right, socialization and engagement. This might be a good time, Maggie, if anybody has any questions.
Yep, we're okay in chat. Nobody has anything so far.
Okay, anybody throwing rotten tomatoes at us?
I don't see anything, but if anybody has a question, now's a good time. Terry's taking a break. Write it in chat and we'll get to it. Okay, we do have one coming in. Okay, this is an incredible presentation. Will we be receiving the slides? I believe
I'm told. Oh, go ahead.
No, I was just going to say, I believe that this is being recorded.
It is, and I believe I was told it's going to be available. Yes.
Yes, through the Bucks County Community College, so that we can double check that and that you know the link as soon as I find out, okay?
Thank you. I didn't even, didn't offer anybody to pay them $5 to call it an incredible presentation.
And the next one was, thank you, this is very useful information. And I also agree, it's very interesting. So thank you so far, we're good.
Okay, all right. And Excuse me one second. Pardon me. I apologize. I had some dental work done, had some issues, so I apologize for the coughing. Much better, much better. All right. So, socialization and engagement to reduce isolation and loneliness. When it comes to helping, what works? Sources of information. Oh, I do remember, was it Lori? Lori presented earlier, and she mentioned several times about the person-centered approach, which is this is what this is all about. Just like in therapy, not everything works for everybody, right? So we just keep trying things that people until we find some things that work for folks. Just like with this, helping seniors figure out how to feel less isolated and not as lonely, person-centered approach works best. Sources of information on what works include research, trials, program evals, and of course, the voice of seniors. We will discuss whether, I'm so happy that everybody came today because our seniors are so important. All right. We will discuss whether behavioral interventions can reduce loneliness. Do we have evidence-based interventions for loneliness and social isolation in seniors, and limitations and future directions? Don't worry, I'm not a big fan of throwing a bunch of numbers out at people. I'm not complaining when other people do it. That's their thing. We're going to do a review and get to what were the end game results. So I want to do just a quick review of how loneliness and isolation can impact a person's well-being. Social, mind, body, it's all connected. Social, physical function, physical health, cognitive function, mental health. Ways to help. So on the outside of the same diagram here, we'll see different activities and programs that may have a beneficial effect on loneliness. I mentioned Dr. Van Orden earlier at the NCOA's symposium I attended in May. She notes that mindfulness training and psychotherapy may be helpful for those struggling with mental health issues. That's my sphere. Right. I do therapy. I incorporate a lot of mindfulness into my therapy. I try not to tell folks straight up, oh, this is, mindfulness, because it can be kind of a word that people are like, oh boy, I don't want to hear it. But we're going to get into that. Volunteering can help with social resources, geriatric care management, technology platforms, home delivered and congregate meals, friendly calling, robotic and real pets, and group exercise. These were all things that have been, are, and want to be looked at / researched as ways to help battle loneliness in later life. So, can behavioral interventions reduce social isolation and loneliness? These are considered non-medicine, right? There are more things like psychotherapy, peer companionship programs, senior centers. As noted, again, I attended NCOA's mental health symposium, and I saw presented one study that presented on a meta-analysis of behavior interventions to reduce loneliness is up here. I put up here. Pardon me. This was 2011. So this is pre-pandemic, obviously. Again, I'm getting some feedback. Are we? Can you hear me okay, Maggie? Because I'm
Yes,
just getting a little.
I can. I did hear a little reverberation, but everybody is just
Okay.
muted. We should be okay.
Okay. Thank you.
Mhm.
So she reported that the folks that did this study, they took all the studies that have looked at loneliness and put them together to analyze the results up until um, this time. So it was population all ages. They were not necessarily lonely at baseline. It was a meta-analysis. So they looked at 50 different studies, all clinical trials, not necessarily randomized controlled trials. Intervention was behavioral interventions. They reviewed what was already researched. The results showed a small but significant impact on loneliness, which is in research is positive. Randomized controlled trials is when we have variables. We have two different groups. We have the group that will receive the intervention, and then the control group that will not receive the intervention. And when I was at undergrad, we not only had to design a study, but also run it and analyze it. And mine actually was on the effects of a single session of mindfulness on levels of anxiety. My study showed a positive, small, but positive result. It helped lower folks' anxiety, but unfortunately, I lost my control group because the whole study was folks from my church, and the flu went around my church at the time, and so I lost my control group, and I could only do it with just a group receiving the intervention, but it still showed a positive result. Behavioral interventions, again, have been shown to be effective to help reduce and manage isolation and loneliness in seniors. A short definition of mindfulness training is the teaching or learning of practices designed to help folks increase their ability to live fully in the present moment. The ability to be present and aware is a powerful counter to the common tendencies to relive past events or to worry about potential events. Worry about past when we tend to fret over the past, we get depressed. And when we start worrying about what might happen in the future, we can get anxious. All right. In undergrad and grad school, both of which happened later in life for me, I attached mindfulness and mindfulness meditation to everything I possibly could. And after and reviewing so much research on it, I'm convinced it helps. The trick is, like with the neck exercises, sometimes turning this into a practical application and like actually doing it can be a struggle. In fact, my brother says everybody should meditate for 15 minutes a day. Unless you're too busy, then you should meditate for a half hour. So, like with other types of changes we want to make or implement, it's a process. I ask people in my practice and therapy to try to allow yourself some grace. We're so quick to allow others grace and time, and yet we put these expectations on ourselves that I have to have this change made by Friday at 4 or it's done. So, all right, mindfulness training. So up here, we found two studies that looked at the effects of mindfulness training. Both were smartphone based. One was from 2012, one was from 2019. The first one, the population was healthy adults, mostly women, ages 55 to 85. The intervention was in 8 weeks of group mindfulness-based stress reduction with weekly 2-hour group sessions, a day-long retreat, 30 minutes daily at home practice, or the waitlist control. Mindfulness-based stress reduction, John Kabat-Zinn is considered like the Western guru of this. He's actually a medical doctor out of Boston. And his book, Wherever You Go, There You Are, is what started me on my mindfulness journey a couple decades ago. And I recently attended a course on mindfulness-based cognitive therapy, um, and he does stress reduction because he's a medical doctor, and he would have to be in psychology in order to, or psychiatry in order to um, consider it cognitive. But he is just unbelievable, the results that he's found if you want to look him up. So the results of this is a group type situation. It reduced loneliness after the program. Again, I'm not going to throw a lot of numbers at you. I'm just going to tell you what we found. And we can supply these or you can find them. The other study later, 2019, the population was younger and middle-aged adults with elevated stress, not necessarily loneliness. It was a randomized controlled trial. Means we have the two groups. It was 14 weeks of daily 20-minute audio lessons via smartphone or the control where they didn't receive any intervention. The results showed reduced loneliness by 22%, increased social contact by 2 additional interactions per day, and 1 more person per day. So Tara Brock is someone I follow, and I've put up here on this slide 2 things you can look into, as well as where to find them on the web. The first is a 23-minute meditation, guided meditation in times of pandemic, calling on your awakened heart. And the next is the acronym RAIN is an easy to remember tool for practicing mindfulness. Again, it's all about just being right here in the moment. And I want to mention thoughts come into just like with anxiety when I teach folks, mindfulness and anxiety the teaching of how to manage anxiety using mindfulness go hand in hand because thoughts are going to come in. We can't control that the thoughts are going to come into our head. I'm sitting here giving this presentation and a thought might come into my head and like, what am I going to make for dinner? But I can see the thought, I recognize the thought, I send the thought on with a grateful nod, can deal with you later, and just bring it right back to here. So RAIN stands for recognize what is happening, allowing the experience to be there just as it is, investigate with interest and care, and nurture with self-compassion. I incorporate a lot of mindfulness, as I mentioned, into my practice as a therapist, and I'm currently, again, working on mindfulness-based cognitive therapy, or MBCT. I'm looking at it specifically for my clients who are seniors who suffer from or struggle with chronic pain and or depression and anxiety to help in my work with them. I share these five free apps that I've put up here with folks. The website because I just ask them to take a look. In my practice, I don't tell people what to do. I tell folks straight up. I'm not going to tell you what to do. If the building is on fire, I will tell you to get out. Otherwise, the only change that's going to happen is the change that you make. So my role is to act as like the map reader and interpreter. And if you want to try something, we try it. But I don't tell people what to do because I believe like that doesn't help them find their power. And I'm all about helping people find their power, not to become queen of the world, but just to be able to better manage anxiety and depression. All righty. I've tried most of the apps that I have put on this website. I like Insight Timer myself. They're all free. They all want to charge a premium, and that's up to folks if you want or can. Insight Timer has 100,000 meditations for free. And I really like it because you can search by topic, like self-compassion, anxiety, pain, and by length. Like I don't have a lot of, no, I don't, I have like 5 minutes maybe some days, 5 to 10. So you can go in and search by 0 to 5, 5 to 10, 10 to 15 minutes along with your topic. So I just put that up here for folks to take a look at. Behavioral psychotherapy, um, or what I went to therapy school for. Research on behavioral psychotherapy is also showing positive results. Here's two studies. The first one was tele-delivered behavioral activation for older adults, 2020. The population was lonely older adults receiving Meals on Wheels. The design was it was a randomized controlled trial. It was 5 weekly video sessions of lay coach behavioral activation focused on social activity, or friendly contacts was the control. The results showed reduced loneliness, increased satisfaction with social support, and increased social interaction at 6 and then 12 weeks. So in studies, they check it at 6, they check it at 12 weeks. Sometimes they check it at 9 months, a year to see how long the effect it has or is lasting, if that makes sense. Engage psychotherapy. This is 2019 and then 2021. This was adults ages 60 plus reporting loneliness and or feeling like a burden. This was a randomized controlled trial as well. It involved 10 in-home sessions over approximately 10 weeks of social engaged psychotherapy focused on social engagement or no intervention. The results showed reduced depressive symptoms and increased social emotional quality of life at 1 week follow-up, and with no effect on loneliness or belonging. But we got an increase in feeling better about being socially engaged, how they felt. Again, we talked earlier about the perception, the perceived ideas. The Solomonov study showed social activities and engaged for depression were the most effective type of activities versus pleasant physical. So it's more when people engage with each other, if that makes sense, socially, if that makes sense. So at Lenape Valley Foundation, the number of intakes had doubled the average surrounding people seeking help with managing their mental health, specifically with anxiety and depression during the pandemic. And we have a wait list. So we began adding more urgent care hours to help folks learn to manage in the moment while they wait, as well as added the number and type of support groups to help folks. This was not instead of a therapist, but rather while they wait for an assigned therapist. And I saw a potential need for a group for seniors. And after discussing with the powers that be at Lenape, I was asked to go ahead and create one. So I did. And in my research at first, when I was thinking about this group, I found most groups on this topic were geared towards caregivers. Not that there's anything wrong with that. As a caregiver, I get it. Then I found this telehealth support group for socially isolated older adults during the COVID-19 pandemic. The creators of the study shared it freely and only asked that they be given credit, acknowledged, and also asked to be emailed, which I did. So we have Rachel Weiss-Kittle and Michelle Linak from the VA Boston Healthcare System, Geriatric Mental Health Clinic, and Home-Based Primary Care. This came out in March of 2020. So their group design was for an 8-week open virtual online or telephone support group for isolated older adults during the COVID-19 crisis. Aims included, I added a few to the original design. I adapted it a bit, but the aims included to increase social support for isolated older adults, to teach group members anxiety and depression management techniques, to strengthen the ability and confidence in the aging process, to become aware of community support, and to present opportunities to share what group members have been through with others. Um, so I adapted it. I ran the first group in the spring of this year. And when seeking input from group members, it was revealed that while they did appreciate and learn from different techniques and strategies taught to help manage anxiety and depression, they more appreciated the social connections they made with each other during the group. They supported each other, they tended to share openly and offer constructive input. They knew it was a new group because I told them, and one member kept calling us guinea pigs, and I told them I preferred pioneers, but okay. So in the end, I made adjustments to the structure of the group, focusing more on social engagement and connection. And again, I'm incorporating managing chronic pain and grief. All these all these topics kept coming up with members of this initial pioneer group. They also asked it to be ongoing. And so I was able to extend it to 12 weeks, and then we'll take a break, and then we'll go back, 1 or 2 week break. And at the request of the members, we moved the time from 12 to 1 to 1 to 2, so folks could have time to eat their lunch. So I'd love to conduct some research. This is kind of like grassroots. We're doing this group, and I'm seeing they're telling me they feel better and they're showing positive results. I wish I could do some official research. Again, we're very busy. So some research has been done on group exercise programs and robotic pets for older adults. It's just fascinating, like some of the research. I forgot how much I enjoyed reading research because I have a tendency to remember the having to find it and all those numbers. Anyway, okay. So community-based group health programs for older adults. The LEAP, leveraging exercises to exercise to age in place study, May of 2020. Population was 50 plus. They were referred by a provider or self-referred. Loneliness was not necessarily an inclusion criteria. It was a non-randomized controlled trial. So they didn't have a control group. It involved meeting with a program coordinator to select an evidence-based program commonly offered by social service agencies. Tai Chi for arthritis, Enhanced Fitness, the Arthritis Foundation's exercise program, or the Healthier Living workshop. The results showed reduced loneliness at the end of the program. Robotic pets for older adults. This is just fascinating for me. In 2018, the population was older adults, including those with cognitive impairment. It was a randomized controlled trial. It involved a robotic pet group meeting 2 times per week for 12 weeks, or care as usual. They also observed interaction with between the folks and a real dog. So it was a robotic dog or a real dog. Results showed reduced loneliness after 12 weeks and actually increased engagement in group with the robotic versus the live dog. I just found that very interesting. All right, other research has been conducted on peer companionship and friendly calling. Face-to-face peer companionship in 2020, this study, the population included lonely older adults. It was a randomized controlled trial. It was 1 year of peer companionship or no intervention. The results showed reduced depressive and anxiety symptoms and feeling like a burden, but no effect on loneliness or belonging. So we got some with the depression and anxiety and feeling like a burden, but they felt I, it, still a positive effect, in my humble opinion. And another study looked at friendly calling during the pandemic in 2021. This was published. It was older adults receiving Meals on Wheels during the pandemic. It was a randomized controlled trial. It was 4 weeks of empathy-oriented friendly calls or no intervention. It showed reduced loneliness, a medium effect size, and reduced depressive symptoms and reduced anxiety symptoms. So when I was in undergrad and in grad school, which actually, again, wasn't that too long ago, in the beginning, I remember thinking, oh my gosh, how much more research do I need to read, review, and incorporate? Then, as time wore on, I realized, yeah, we're going to need more research on this or that or whatever it was. So I started including a slide, something like this, up here in my presentations and talks, because we need more research. Now, while the research being conducted looks promising, I mentioned earlier the voice of older adults, like in my group. I found this article titled "Older Adults Report Better Mental Health Than Younger Ones During Pandemic." This is from March of this year, written by Barbara Stepko. She notes that older adults, oh, pardon me. She notes that older adults have been particularly hard hit by the COVID-19 pandemic and that they're at a far higher risk of experiencing complications from the virus, which we know, and many have suffered from the mental health effects of isolation from families and friends, again, as we know. But in this, she noted about 25% of people in their 60s reported having symptoms of anxiety in the previous 7 days. For instance, in a February 2021 household pulse survey by the National Center for Health Statistics and the Census Bureau. She writes that despite this, the older population has held up remarkably well compared with the population at large, according to experts. And in fact, adults ages 18 to 29 were far more likely to report symptoms of anxiety in the survey, like almost at 47% did so. So they think it has to do with resilience and weathering storms that can come, the ability to weather storms that can come with the aging process. So, all right. This is a good time if we want to see if anybody has any questions, comments. Are we here?
We're good with chat. Nobody, just people thanking you for the great presentation. Terry, I did post that the PowerPoint will be available. I double checked with Holly, just so everybody knows, but it's going to be available on the Community College YouTube playlist within the next 1 to 2 weeks. It takes a little time. So,
Yes.
okay, so that
Yes.
other than that, everybody's just thanking you again.
Yes.
Could you please say the apps you enjoy for time frames and topic searches and mindfulness meditation? If you could just go over those again. Everything else is just positive thank yous.
Sure. The one I use is Insight Timer. And on these slides is the link to take you to, it's mindful.org. Pardon me. I think, well, I may have it again in here, is the link takes you to mindful.org's an article on 5 apps worthy of your mindfulness apps worthy of your attention. But again, Insight Timer is the one I use now. All right, self-care. I know. So you may or may not have heard the term self-care. Some people think of it as like sitting cross-legged on a pillow like this, going, And when I introduce mindfulness to my clients, I actually even avoid using the word at first because, again, people get this. It's been kind of stigmatized, right? It's like, oh, yeah, no. I tell them straight up, I don't have time for that. I'm not going to ask people to think about doing that. So I don't ask folks to do that. And you can see on the slide, I've got brain breaks up here. What else? Definition of self-care again, and types of self-care. But before we define and talk about it a little more and what it can do, I'd like to take a quick brain break. Brain breaks are a quick and effective way of changing or focusing on the physical and mental state of participants in a group. I was in a cognitive behavior therapy training, trauma training, and this brain breaks came up. And I know that it's used in schools. Teachers use it for children to give them a break, and research is showing, yeah, it helps adults too. So it indicates that research indicates that brain breaks also improve concentration and relieve stress. This is again is a little bit of micro self-care. Macro self-care is all about I'm going to take a vacation in Fiji or down the shore or in the mountains for a week or 2 weeks. Micro self-care is little things that you can do in the moment, just in between meetings. Um, Fidgets may look like toys, but are serious tools to help participants increase focus and attention while reducing stress. So I've got my little thing. I sit here and use this. It's just a little thing. Somebody shared in my self-care group up here, our monthly self-care group, they shared they have a self-care tray on the corner of their desk. And they got it and they added stuff to it and they all excited about a self-care tray and that it had so much dust on it. Um, Therapists are not the best at giving ourselves self-care either. But anyway, so I'm going to do a quick brain break. I can't see you guys, so I'm just going to, you can do it or not. You can get your coffee if you want. But this is tap, snap, clap. So we're just going to do tap, snap, clap. Tap, snap, clap. You can do it with me. You can just watch me. Tap, tap, snap, clap, clap. Tap, tap, snap, clap, clap. Tap, snap, clap. Tap, snap, clap. Tap, snap, clap. Tap, tap, snap, clap. Tap, tap, snap, clap. Okay. Self-care. This is the definition by the World Health Organization: the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. So a holistic approach, when we're talking about the mind-body connection, like we were today, surrounding how isolation and loneliness affect our seniors, I wanted to share how taking a holistic approach can benefit all aspects of a person's well-being and health. Up here is a mental health self-care wheel, which encompasses physical, psychological, emotional, spiritual, personal, and professional aspects. Like we saw earlier, in the diagram that Dr. Van Orden had shared, the same. We have the physical. All of these things also affect physically, emotionally, mentally, and so it's kind of like when we pay attention to all of it as a whole, we can we can create a more person-centered approach to helping people feel less isolated, less lonely. One, two, three. Just breathe. Deep breathing is one of the best ways to lower stress in the body. This is because when you breathe deeply, it sends a message to your brain to calm down, man, and relax. The brain then sends this message to your body. Breathing exercises are a good way to relax, reduce tension, and relieve stress. I love deep breathing. It's pretty good. I can market it pretty well to my clients to give it a try because I can share with them, like, it's portable. We carry it with us wherever we go. It's free, right? And there are many types of breathing. Some people can get tripped up, and I'm not saying there's nothing wrong with the many techniques of breathing out there, like square breathing or alternate nostril breathing. But I find some folks can get tripped up in the mechanics. So I just started doing 1, 2, 3 breathing. Breathe in for 3 and breathe out for 3 and breathe in for 3 and breathe out for 3 and breathe in for 3 and breathe out for 3. Kind of like a waltz. 1, 2, 3, 1, 2, 3. And then I do have to explain to some of my clients what a waltz is, but that's another that's another topic of discussion. I also suggest folks put a note on their, I have one here. Do I have it? Yep, I have it right here. Hold on their bathroom mirror or door jamb, just to give them an idea to remember. Practice it twice a day. When you brush your teeth, in the morning and at night. Well, not when you're brushing your teeth, do the breathing, but not exactly while you're doing it, but at that time, so that it can become more of a habit, just like with the neck exercises. So I'm not doing them only once a month. Um, okay. I also follow Linda Graham, and today I put up the hand on the heart exercise. If you want to try it, it's very good. It's something that you can, I don't think we're not going to have time to do it today, but I have the website up there. And 3 ways to tap into the wisdom of the body. She presents a full toolbox of practices to help you meet the chaos of life with awareness, acceptance, and deep knowledge that you have the strength to work with it all. It's just somebody I kind of connect with on how she rolls with mindfulness, we'll say. Okay. I've also put up here a link to Wellness Society's Coronavirus Anxiety Workbook. It's good for it's not just pandemic related. It's a tool to help build resilience during difficult times. It's got things to help manage, it goes into a bit more detail on what anxiety is, tools to help deal, and some more about control. Practical wisdom about tolerating uncertainty, how to challenge thoughts to help reduce anxiety, because a lot of my folks are surprised when I share with them that not every thought we have is true. They're like, wait, say what now? Yeah, no, not every thought we have is true. And we can challenge them. And when we can prove that they're not true, we don't have to believe them, especially those negative self-talk thoughts people have about themselves. All right, let's see how to challenge thoughts. A lot of distraction activities, which actually can be an effective technique for managing anxiety in the moment, and creating an action plan to help build up resilience and stress. It also offers further free resources. All right, that ends my talk for today. Again, I'd like to thank the folks at Bucks County Area Agency on Aging for inviting me. I'd like to thank Maggie for your help. I really, really appreciate it. I'd like to thank all of you for allowing me to talk for so long. I was like, how am I going to fill all this time? And I'm Irish. I mean, I know how to talk. I enjoy it. But I hope I've been of some service and help.
Yep,
Thank
you're
you.
getting really good responses in the chat. People are so happy for the great presentation and your thoroughness. Um, you might want to take a peek at some of these just because everyone is just so thankful for your presentation, myself included. And I loved all the mindfulness and apps sharing that you did. That's great in the exercises. So thank you for all of that. It does look like we're coming up on break time, so everyone needs to take their lunch apparently from 12:10 to 1, and then the breakout session for the afternoon starts at 1. So, Terry, if that's all you have, I guess we can let everybody go a couple minutes early.
That's all I have. Oh,
Okay.
this you can consider this self-care time. Woohoo!
Thank you. Thank you so much. Have a
All
good
right,
day,
thank you.
everybody.
All right.